Hello everybody. Today we're going to be discussing how conventional imaging impedes precision oncology developments for men with advanced prostate cancer, particularly those men with bone disease. Here are my disclosures. For precision oncology developments to occur, we need to have confidence about the true clinical states of patients, and also be confident about the therapeutic effects of new treatments. Currently, we rely on bone scans and CT scans, which are unable to predict the presence and extent of metastatic disease, which results in late detection and volume underestimation of metastatic disease, which in the clinic misdirects the therapeutic approach. Bone scans and CT scans do not enable us to identify patients who are not benefiting in a timely fashion, which means we fail to rapidly respond to primary and secondary therapy resistance, impeding patients' progress to alternative therapies. And bone scans and CT scans only have a limited ability to depict the heterogeneity of response, and we know that the heterogeneity of response is very important for predicting patient outcomes. Here's an example of a patient developing 2 new bone scan lesions shortly after starting enzalutamide treatment. What are these lesions? These lesions are called unconfirmed new bone scan lesions and can be seen in 20–25% of patients being treated with enzalutamide or abiraterone. These could represent true progression. This could represent tumor momentum, temporary worsening of the bone scan appearances prior to a delayed cytostatic androgen withdrawal response. Or this could in fact represent an early osteoblastic reaction, which is a response. Sometimes this is called bone scan flare or pseudoprogression. Because we're not clear at this stage, the Prostate Cancer Working Group 2 requires the application of a 2+2 rule. That is, new bone scan lesions developing in the flare period, the first bone scan, should be confirmed by the documentation of additional new lesions, more than one, on a follow-up scan, provided there are no other signs of progression. And in fact, when we follow this patient over time, you can see that the patient does appear to be responding to enzalutamide, so this in fact was a bone scan flare. So this pseudo-progression bone scan flare reaction has been documented prospectively in 2 large clinical trials with enzalutamide treatment and abiraterone. Let's look at the validation of the unconfirmed new bone scan lesion. So if you develop 2 new lesions and then develop no further lesions, or only 1 additional lesion on a follow-up scan, that is to say the blue line here, your survival is better than if you develop new lesions. This validates the 2+2 rule. However, new data has recently emerged suggesting that new bone scan lesions in chemotherapy-naive men likely represents early treatment response. This has been shown in the PREVAIL trial. However, the AFFIRM trial, which was done post-docetaxel, new bone scan lesions may in fact represent true progression, being associated with worse overall outcomes. And the authors from this paper suggest that functional imaging should be used to clarify the nature of unconfirmed new bone scan lesions in people who have had previous docetaxel prior to enzalutamide. So strategies to overcome the limitations of the bone scan flare response include applying the 2+2 rule, in other words, keeping the faith and waiting for the next bone scan, correlating with clinical assessments, which includes PSA and CT monitoring, or using functional imaging for characterization and response assessments. So how good are clinicians at deciding how well patients are doing using clinical response criteria? There isn't very much data on this, but some interesting data is beginning to emerge. In hormone-sensitive prostate cancer, symptoms and PSA are usually considered as sufficient monitoring tools, but we know that PSA discordant progression, that is to say, clinical or imaging progression in the absence of a PSA rise, can occur in up to 30% of patients, and I'll show you the data for this in a second. And in castrate-resistant prostate cancer, although symptoms and PSA are commonly used, they are increasingly being recognized as being inadequate. And in fact, PSA discordant progression, that is to say radiographic progression, without clinical or PSA progression, has also been noted in 20 to 30% of cases. Here, for example, is the data from the CHARTED study, which looked at hormone-sensitive prostate cancer being treated with docetaxel chemotherapy. This study showed PSA discordant progression in about 30% of men receiving docetaxel. You can see clinical progression without PSA progression in high volume disease occurs in about 30% of patients, but the data are nevertheless fascinating because they do show that even in the hormone sensitive state, that radiographic and clinical progression can occur without PSA progression occurring. In fact, it turns out that there are suggestions that PSA discordant progression may predict for a more aggressive course of disease. It's interesting to see that the Advanced Prostate Cancer Consensus Conference panelists still don't recommend regular imaging for assessing response in metastatic hormone-sensitive prostate cancer. We also know that there are significant limitations for PSA monitoring for metastatic castration-resistant prostate cancer. A number of guidelines recommend regular monitoring for these patients. This is on the basis of radiographic progression occurring in the absence of clinical and PSA progression in between 20 and 30% of cases. And this is particularly for patients with metastatic bone disease who can develop soft tissue progression when they initially start with bone-only disease. And we know with radium-223 that PSA is an ineffective response assessment parameter because non-bone disease progression occurs in about 50% of patients within 3 to 6 months of starting radium. In fact, this study was published recently looking at the PREVAIL data showing that non-rising PSA at radiographic progression occurs in about a quarter of patients with castration-resistant prostate cancer being treated with enzalutamide, and the authors suggested that a serial disease monitoring strategy should be used. So the guidelines also recommend this, that there should be regular imaging of some sort in men with metastatic castrate-resistant prostate cancer. However, we do know that functional imaging can be effective in assessing therapy response in advanced prostate cancer. So, for example, this 52 patient study has recently been published in 52 men with metastatic advanced prostate cancer receiving some sort of systemic therapy with or without radiotherapy. These authors compared PSMA PET CT scans with PSA dynamics and showed that there were concordant responses in only 65% of patients. Discordant responses were seen in 35% of patients, mostly in men in whom PSA was stable, but there were some men who were progressing while the biochemistry was stable. The main value of imaging appears to be the ability to look at individual lesion responses, which is in contradistinction to the PSA measurements, which are of course a more global assessment of therapy response. Imaging flare responses have also been described for other imaging techniques. So the osteoblastic reaction would be expected to cause flare responses with sodium fluoride PET and CT scans, and this has been found to be the case. PSMA PET can also cause flare responses. Here's an example of a man responding biochemically to enzalutamide, and you can see that the patient is developing a PSMA flare response despite biochemical response. You can see this flare response developing in this vertebral body, corresponding to an increased mineralization on the CT scan. These flare responses are in fact very heterogeneous, and changes in PSMA uptake early on may not predict the subsequent clinical response or progression of patients. Flare responses such as these have not really been described with MRI techniques. Here's a man being treated with enzalutamide for metastatic castration-resistant prostate cancer. At week 25, you can see that the PSA is suppressed, PSA 0.2. At screening, it was 45. And we see a new lesion here on the whole body MRI scan, which we can confirm by zoomed up views on the whole body MRI scan. At this stage, you can see that the bone scan is clear. The patient continues on enzalutamide, and you can see that the PSA does not really change, but we see the emergence of 2 lesions on the bone scan and 5 lesions on the whole body MRI scan. Now the 2+2 rule requires confirmation of the bone scan appearances, and the patient therefore continues on the same treatment. Then you see a rise in PSA. Subsequently, you see deterioration of appearances on the bone scan and on the whole body MRI scan. So this is the date of oligoprogressive disease. This is the date for metastatic disease progression using the prostate cancer working 2 group criteria, and of course the recorded date is week 37. This need to wait to confirm polymetastatic disease progression before declaring progression means that bone scans are probably not suited for directing precision oncology developments. The whole body MRI technique that I've just shown you is in fact very effective at demonstrating the biology of bone disease. So for example, if you were to drill the bone marrow and correlate ADC values, signal intensity values, and the fat fraction in these areas, you can see that the lower the ADC, the greater is the cellular fraction. The higher the signal intensity, the greater is the cellular fraction in bone marrow trephines. Whole body MRI scans can also enable cellular viability habitats to be spatially mapped. So here's a man receiving docetaxel before and after 4 cycles of chemotherapy for metastatic hormone-sensitive prostate cancer. And what we see is there's a histogram shift to the right with treatment. This histogram shift to the right represents cell kill as demonstrated on this cartoon. It is possible to back map ADC values onto the whole body and color code them for disease that is alive, dying, or dead. In other words, to reflect disease where there is no treatment response, where there is likely to be a response, or where there is highly likely to be response. And here in this man you can see that the total population in red, disease where the tumor cells are alive, starts off at 95%, and after 4 cycles of docetaxel you can see it amounts to 35%. Not only that, we can also spatially map where the disease resistance is developing. So in this particular instance you can see there is disease resistance in the right ischium, in the sacrum, and in the left femur. It is possible to then drill those areas to look for mutations. And this was done in this particular study. So the left iliac bone posteriorly was drilled and BRCA mutations were noted. The patient was treated with olaparib, and you can see the ADC value goes up, indicating a therapeutic response. But look what happens later. Later on, the patient appears to be developing an abnormality in the right iliac bone, and when this area is drilled, you can see there is reversal of the BRCA mutation. In other words, you can use imaging to guide a biopsy to look for actionable mutations. So it is possible to use tools such as this to monitor the response to therapy across different treatments at different time points in a patient's journey. This ability to use ADC to report on cell kill was used in this experiment where 2 different doses of radium-223 were evaluated. Half the patients in this study received 55 kilobecquerels and half the patients got 88 kilobecquerels, and therapy monitoring was done with whole body MRI scans. You can see that there is marked heterogeneity between lesions and between patients occurring at both doses in various lesions. However, it is interesting to note that at higher doses there are greater increases in ADC values, suggesting that the higher doses is likely to yield a greater therapeutic benefit than a lower dose. However, we do need to acknowledge that there are barriers to the adoption of next-generation imaging technologies in men with advanced prostate cancer. There is a general resistance to changing current staging and treatment paradigms. We know that economic forces vary between countries, which creates challenges to the unification of imaging technological applications. And we also are aware that clinicians themselves are not consistent on how to use next-generation imaging results for managing patients. However, next-generation imaging technologies will be required for next-generation clinical trials based around precision oncology. Let's take the example of PSMA-directed therapies. Here's a recent study that has evaluated PSMA radioligand therapy, monitoring responses with PSA as well as with total tumor load, segmenting out the tumor volume on PSMA PET scans. Here are the correlations between PSA changes and overall response and total tumor volume and overall response. You can see that the change in tumor volume is a much better correlate to survival benefit compared to PSA. This has led to a phase 2 trial, again showing very similar results, and phase 3 trials of radioligand therapy have begun. From this, it's very clear that next generation imaging technologies need to be used to drive precision oncology developments. And here is a schema where we think next generation imaging should be used to promote precision oncology for all men with prostate cancer. You can see that MRI is recommended in the early part of a patient's journey. PET-CT scans, particularly with PSMA, for biochemical recurrence, for staging high-risk locally advanced cancers, and of course right at the very end for PSMA-directed therapies. And we feel that whole body MRI scan should be used to monitor treatment along the journey. So here are my take-home points. It's really time to move to next generation imaging for men with advanced prostate cancer. Next generation imaging, which includes PET scans and whole body MRI scans, can detect metastases with higher sensitivity. Early detection of metastasis and the early detection of therapy resistance can have positive precision oncology implications. Remember, next generation imaging positively assesses therapy response and identifies therapeutic failure earlier. Remember that bone scans can only identify late tumor progression. This ability to show heterogeneous responses can have therapeutic implications. We agree that next generation imaging methods have not been shown to be completely validated and have not been evaluated prospectively in clinical trials, but we are ready for clinical trials incorporation with multiple standards now available for both whole body MRI scanning as well as for PSMA PET-CT. Thank you very much. I hope you enjoyed this video.